A great every day above ground is a great day, right?
Yes, sir.
Every day above ground is a great day. So cool. So
That's
excellent,
right.
excellent. So I guess we're
All
gonna go
right,
ahead and
gentlemen.
do this again, and we're gonna yeah, let's see if we can provide a little bit more knowledge for folks.
All right. All right, ladies and gentlemen. That one went out to finish with band of thing here at WPOE. Happy birthday once more. Ladies and gentlemen, it's past time now for the Health Fest. Health Fest coming to stay tuned with
All
Dr. Brown.
all right, thank you for that wonderful introduction. It's always good to talk to the folks down at down in North Carolina, and always good to talk to folks in Ohio, and hey, the rest of the world, right? But good afternoon, listeners. You're locked into WVOE 1590 AM, the voice of Ebony, where your health is our heartbeat. I'm your host, Dr. Christopher Brown, president and founder of Pressure MD Academy, welcoming you to another enriching session of Health Facts, the show where wisdom meets wellness and knowledge is always in season. All right. So like I said, thank you everybody that's listening through WVOE. Thank you for everybody that's tuning in to the live stream, whether it's on Facebook or YouTube. Appreciate you checking us out. Also, if you're watching a recording, we appreciate that as well. All eyes are good eyes. I guess we can say that, right? So thank you for tuning in. And of course, this time we're talking about kidneys. We've been talking about kidneys for the last 2 weeks. Why? Because it is National Kidney Month. So we want to make sure we pay attention to those kidneys, and that we are doing what we need to do to keep ourselves healthy and to protect those kidneys, and that if there is a little something going on with the kidneys, that you're able to monitor them properly, and do what you can to to take care of them and keep those kidneys as long as possible. So that's what we're here to work on. So this week, we talked about what the function of the kidneys, what chronic kidney disease is. This week we're going to be talking about really two different but kind of overlapping topics, really. And that's going to be, what we call end-stage kidney disease. So last time we talked about chronic kidney disease, the fact that it has multiple stages. And we touched a little bit about that stage 5, which is when that kidney function drops below 15, 15, we say percent, but it's really just a number 15. And what happens when it drops below, touched on what happens when it drops below 15, what to expect, because that's the level when you're looking at really kidney failure. So that kidney may not completely fail at the number 15. It may be closer to 5, it may be 10. It's different for every person. But really, once you're at stage 5, this is when, people are being placed on what we call dialysis. And so that's what we're going to talk about today. We're going to talk a little bit about that. Then we're going to venture a little bit into a cause of kidney disease that is not as well known, but is increasingly important, and that's a gene called APOL1. Okay, so let's go ahead and start talking a little bit about this end-stage kidney disease, and we want to start with a few statistics, and one in particular, and that is the fact that that unfortunately kidney disease within African Americans is much higher than it is in the general population. Okay, so you know, African Americans make up about 13% of the US population, right? But unfortunately, make up about 35% of the people with end-stage renal disease, end-stage kidney failure. Kind of the same terms, and so there's really, that's a multiple, like 3 to 4 times higher, and it's really impactful because we'll talk a little bit more about that, but like end stage kidney disease is a significant game changer in your life. And so the question becomes, why are African Americans more susceptible? And there are a lot of different things that go on there. Like I said, there's higher rates of high blood pressure, higher rates of diabetes. And what did we say was the number one cause of chronic kidney disease before? Diabetes. What's the number two? Hypertension. So we got higher rates of both of those, and so it kind of just it goes from higher rates of those to higher rates of kidney failure, unfortunately. Okay. And some of it is less access to preventive care. They may not be, primary care clinicians. They're hard to find anyway. And like I said, in some neighborhoods, it's extremely high, or you got to travel a lot further. So that can be tough. Plus, there's like social and environmental factors that can play a role. And stress, really, and we touched a little bit about this on our talk about hypertension. Stress is not to be underestimated. Stress releases some bad hormones inside of our body. It drives our blood pressure up. So and then when it's constant stress, that's constant badness, if you will, going on inside the body. So that's one. So those are some of the reasons. Those are some of the things that contribute to the factors that increase our rates of end-stage kidney disease. Okay. And now we're finding out that there's a genetic component. There literally is a gene, that APOL1, that can also contribute to, and let me put this on this do not disturb. I forgot to put that. So, and then there's also this APOL1 that they're finding more and more can contribute to kidney disease. As a matter of fact, there was one study especially when looking at hypertension, because we are particularly vulnerable to end-stage kidney disease by hypertension. And they were thinking that this APOL1 gene may explain the majority of the discrepancy in people that wind up on dialysis from hypertension. If not all, but like I said, a big part of that discrepancy between us and other folks may be due to this APOL1 gene. So, that was a hypothesis someone had there. So, kind of going back into your, back into the end-stage kidney disease. I know I'm kind of jumping around a little bit today, but so end-stage kidney disease is whenever your end-stage kidney disease or active CKD stage 5 is when your kidney function falls below 15%. And like I said before, CKD5 is below 15%. When you wind up on dialysis is kind of variable. Some people get on a little earlier, some people get on a little later. And what happens is that, when that is below 15%, different toxins and fluids start to build up inside the body. And it's because the kidney is just kind of wearing out. We talked before about the analogy between the eGFR, and that's how we follow our kidney function, and a battery gauge. And so, like the way when you have a battery and that number keeps going down, you lose battery power. Same thing happens with the kidney. So, like, as they start losing that eGFR, that's losing those eGFR units, and that eGFR goes down, your kidney keeps getting weaker and weaker. And so it's the same. Sometimes you have a toy, or some scales or something of that nature, and that battery power is down, and maybe the toy functions a little bit, but just not in the same way it did when it was back at 100%. Same thing with the kidneys. So your kidney number at 15 is functioning a little bit, but not the same thing it did when it was at 60, when it was at 70. You just lost a lot of that kidney function. That kidney is doing what it can, but it's just not able, it's just not able to keep up. And then as that number keeps dropping, those signs and symptoms will get worse. So you'll start getting more toxins, more fluid buildup. And a lot of the symptoms that occur are things like, severe fatigue, because like I said, the toxins are building up. And then also, like I said, remember what we said about the kidney, it creates a hormone that creates your red blood cells. So it can't do that no more. So now you got significant anemia. So you're really weak. So you got that going on. You got your shortness of breath, because guess what? If you're anemic, you can get short of breath. If fluid builds up and it might be in your legs, later on may get hitting your lungs, you're gonna get short of breath. So you get swung in the legs, nausea, and there's a particular situation where you become very averse to meat. Like your meat will taste like metal. So like I said, and that's really a, hey, you need to start dialysis now. That's not a later thing. That's an emergency. And then, like I said, difficulty concentrating. Those toxins can interfere with your ability to think. Okay, and at that stage, what you're looking at is our fancy name for it is kidney replacement therapy. Kidney replacement therapy, and basically, what that term refers to is that we have to replace what your kidneys are doing. Okay, and the most common thing that we know of is what we call dialysis. And it's usually either dialysis or kidney transplantation, and we'll talk about a little bit of both of those. So the dialysis, there are two main types of dialysis. There's what we call hemodialysis, and this is when we get access to the blood. So either what we call a fistula or what we call a catheter, and you basically connect yourself to the machine. The machine will take blood out, it will clean it, it will take extra water out of there, and then it'll return it to the body. And you'll do that several times a week. Now, within hemodialysis, there's a type you can do at home. There's a type you can do inside of a center. So you do have two types. Most people are going to know about the dialysis center, and you usually go there usually 3 times a week, and it's usually 3 to 4 hours a day. So it does interrupt people's lives. So but that is what that hemodialysis is. You go in, you attach yourself to the machine cleans the blood, takes the extra fluid out, puts it back in. So that's what that does. And that's the hemodialysis, and it can be home hemodialysis, or it can be in center hemodialysis. Then the other thing we have is that it's actually kind of interesting because it's called peritoneal dialysis. Big old long name. But long story short, there's a little space inside of the abdomen, and you can put a catheter in there. You can infuse fluids in there. And while it's in there, the fluid kind of helps to absorb some of the toxins. And actually it can also absorb some of the extra fluid. And then you just drain it out. So, and then, like I said, you do that. And it used to be you would do it throughout the day, but they actually have very sophisticated machines now where you can get that catheter put in. You can connect yourself to the machine at night. It will put the fluid in, let it sit a little bit, drain the fluid out, and it'll do that several times throughout the night. And then the next day you disconnect, put everything off, and then you go about your day. So a lot of people, sometimes like that. Now, of course, if you're at home, a lot of the work that's being done, say inside of a center, is being done inside the home. But of course, it also means that you don't have, you'll be inside your house. So say that you had a work from home situation, or maybe that there's stuff you want to do, it can be done there. Or even for regular work, you go to your work, you come back home, you eat your dinner. When it's time to go to bed, you connect yourself, and the machine will do the majority of the work. And you disconnect yourself the next day and keep going about. So you do have those options. So the dialysis options are the hemodialysis, which uses the blood, and the peritoneal dialysis, which uses a special fluid inside of the a space inside the abdomen. So those are the dialysis options. Now, the other option is what we call kidney transplantation. Now, while we do have dialysis, and dialysis definitely works well enough to keep you alive, it doesn't replace the function of the kidney. For people that are on hemodialysis, the estimated annual mortality rate is about 20%. So basically, they estimate that most people are not going to make it before about 5 or 6 years. Is about the estimated time they're thinking you might be alive when on hemodialysis, because it's rough on the, it can be rough on the body, and it doesn't replace the kidney function completely. Now, kidney transplantation is when you get basically someone else's kidney, you get it put inside a special place on your body, and you basically replace the function of your kidney. So that's what we call kidney transplantation. Now, there are two different types of kidney transplantations. There's one where you get it from a healthy donor, and that's a living kidney donation. And those are the best ones. Those are the best ones. We get someone that's already healthy. And like I said, like we said before, you got two kidneys. And so that person decides so graciously to give you one of their kidneys. Of course, there's testing to be done to make sure that you're compatible. So that gets done. And then you get that in place. And as long as it doesn't reject, then, like I said, it should function like that normal kidney should do. So that's We love when we get the chance to see that, but unfortunately, of course, a lot of times that doesn't happen for a lot of people. And so the other one is a kidney that you get from a person that has passed away, a person that's deceased, and that's when you're on a transplant list, and they'll give a person a call and say, hey, we got somebody that's able that has a kidney that's compatible with your blood type and a lot of other tests, and then you go in and they put that kidney in and hope for the best. They got medications and things, and same thing. You're always concerned about the possibility of rejection. So those are the ways that we can replace the function of the kidney. And so we do have dialysis. Dialysis is what majority of people get, but you do also have kidney transplantation. All right. So that's kind of the summary for what we call end stage kidney disease. And that's where that kidney has kind of, the kidney number has kind of dropped down below 15. And you have these symptoms that we kind of described. And at that point in time, you and your nephrologist will have to discuss, when you're going to get on dialysis or get on kidney replacement therapy. Now, the other thing we want to make sure you remember, and that is that for those people that have chronic kidney disease and you find that your kidney number is less than 20, you can discuss with your kidney doctor, being referred for transplantation. You can get referred even before you're on dialysis. So I always want to make sure people remember that piece. All right. So, all right. So that was a lot. Actually, that's a lot. So we'll take a little breather, and we're going to go into this next topic, which is what they're finding. I guess it's been around for a little while, but like I said, it's really becoming a little more popular. And this genetic link to kidney disease, and of course, genes control everything in our body. There are all kinds of genes. Polycystic kidney disease is a type of kidney disorder that is a lot of times is linked to your genes. But this special one seems to be linked to the descendants of certain areas of West Africa, and it's called APOL1. Okay, and it's a gene variant that occurs most frequently in people whose ancestors came from the western part of Africa. And the reason why this gene came around, it actually was, historically, it actually it was actually protective. So in West Africa, they have a disease called African sleeping sickness. And this gene occurred, and it actually helped people. It helped protect them from this African sleeping sickness. So that's why it became so prevalent in that region, is because it was there to do a job, right? So, unfortunately, or I guess, what happened is that once people kind of migrate, well, I don't know, migrated, people were taken from West Africa, and kind of, distributed. I don't know if that's the right word, but like I said, doing the slave trade, transatlantic slave trade, the Caribbean, South America, and of course North America. That gene traveled with the individuals that were brought here, and so what they're finding now is that gene seems to be related to kidney issues. Now it's kind of interesting because, number one, just because you have the gene doesn't mean you're definitely going to develop the kidney disease, but it does increase the risk. Okay. And then the other thing is this, and because this gene, you get one of those genes from you get one set of genes from your mother, one from your father. And so with this APOL1, so it's a variant. So say that your father has this APOL1 variant, your mother does not. So you wind up getting one that's a variant, one that's a normal type of version of this gene. Those people tend to not develop kidney disease at a higher rate. Now they're still looking into this because, of course, they have to track, and you have to get some information. But that is, so far that doesn't seem. So you just have one. Those people seem to be okay. I think we're going to have to study a little bit more to make sure to confirm that. And of course, if you don't have any of that, then you're fine. But like I said, what happens is that when you get one of the variants from your father, one of the variants from your mother, and you basically have two that are variants, those people do seem to be at higher risk of kidney disease. And it could be, there's different sorts of causes that we didn't go in. We did not go into all the causes of kidney disease. Just letting you know that we went into the ones that were most common. But there are conditions such as lupus, and those and lupus, actually HIV, and there's a lot of other things that can cause damage to your kidneys that we didn't go into. But if you have these two variants of this APOL1 gene, then those people seem to be at higher risk of not only developing kidney disease, but developing it earlier, developing it more severely, and being more resistant to treatment. Now, I mentioned before about the issue with hypertension. So hypertensive kidney disease seems to be unique, and not that it's only, but like I said, it seems to be uniquely positioned within the African American community. And there's some studies that indicate that those people that are developing kidney disease from hypertension this may be because they have the two APOL1 variant genes. And so this is going to be, of course, they're looking into this. It seemed to be pretty solid, but that's where that seemed to come from. So a lot of times and like I said, when I see people, and I see especially hypertension, and especially hypertension that has protein, because you're not supposed to have that, I always kind of recommend that they get tested for this APOL1 gene. And what you'll find is like a lot of them are going to have the two genes. And it used to be, initially when you hear about it, it's like, okay, well, if you get tested, what you're going to do? Right now, it's interesting because they're actually studying therapies for this, for people that have kidney disease related to this APOL1 variant. So before, it would be you would find out and it'd be like, well, just eat healthier, be healthier, the things that we were telling you to do anyway. But it looks like now that there are some clinical studies that maybe we could see some treatment for people that have this disorder. So now it's becoming more important for people to get tested if you have chronic kidney disease, and especially if you have chronic kidney disease at an early age, or if you got like a family history, getting African Americans tested for this is becoming increasingly important. Okay, so that's the APOL1 gene. So like that's just something to keep in the back of your mind. If you have kidney disease, if you have a family history of kidney disease, and you're like, hey, is there something going on? There are tests that you can do, the genetic tests, and it's interesting because the genetic tests are two different types. You can test just for this abnormal gene. Boom, I'm going to test with this, and that's it. Or you can test for a panel of genes. So say that you have chronic kidney disease, maybe you don't know your family, or maybe there's family history, but you're not sure what it is. You can always say, hey, look, test me for a panel of genetic markers, and they can check to see if you have one of the known markers for kidney disease. Because always remember, they're always studying this, and so if you get the panel, you can see whether or not you fit any of these genetic profiles. Okay. All right. Whew. Okay. So I feel like, it's interesting because I feel like this is not as long a section as I've had before, but it feels like there's a lot of information that's coming towards you. So we want to take a moment here and kind of go over what we discussed. So the big thing we discussed today was end-stage kidney disease, end-stage renal disease, and that happens when your kidney number, that eGFR, drops below 15, and also whenever you have symptoms and you wind up getting on kidney replacement therapies. And of course, the kidney replacement therapies that you have to have that conversation with your kidney doctor or nephrologist. Remember that big old word, nephrologist. And you have a choice between hemodialysis, peritoneal dialysis, and then you also have kidney transplantation. So those are the things for kidney replacement therapies. And that's for that. And then the APOL1 gene is a special gene. It's a special gene that is associated with the descendants of West Africa. Like I said, that gene initially was there to protect people from African sleeping sickness. Unfortunately, it seems to be associated with, with people that have a family history of kidney disease, people that develop kidney disease at an early age, and people that have a more severe kidney disease. And so, it is still being studied. Fortunately, right now, some of the clinical trials are actually looking at treatments that may be able to help people that have kidney disease secondary to this APOL1 gene. So that kind of wraps up our talk for today. And of course, the things I want you to remember are, number one, because this kind of wraps up our 3-part series. So what we want you to know is what chronic kidney disease is. So that's very important. Make sure that you know that your numbers. So if you're at risk, so if you have high blood pressure, diabetes, honestly, you should be getting this, checking on your kidneys and at least once a year. So make sure that's happening. And like I said, you want to know that eGFR number, and you want to know that albumin to creatinine ratio. Ask about, hey, is there any protein in my urine? So those are things you want to make sure you're finding out about. Know your family history. That's important as well. And like I said, if you need genetic testing, make sure you can ask for it. You can, if you have the risk factors, fine. You can also ask if you just are curious. Like I said, hey, I got chronic kidney disease. I just want to know. So you can always ask about that as well. So thank you all for listening here. Like I said, as always, I always like to give my disclaimer that I'm a doctor, not your doctor. Unless you sign up, you can sign up. So feel free to do that. And, always feel free to go to, this is Pressure MD Academy. But if you, so you can always reach out to Pressure MD Academy, which is on thedocbrown.com. That's our website. And if you got questions about just kind of general questions, you also, if you say you want to get, hey, I want to get APOL1 testing, nobody will test me, you can also reach out to Pressure MD, which is a clinic, and that's www.pressuremd.com. Feel free to call, pressuremd.com, and you can always reach out there. We can get you connected for the genetic testing, and they can be done through telemedicine, so you don't even have to come into the clinic. And that's pretty much the show for today. So make sure you're proactive, not reactive. I think with these 3 sessions, I think you have enough to really have a great amount of knowledge about your about your kidney function, or how to screen for your kidney function. If you have chronic kidney disease, you know how to follow it. So hopefully this has been helpful. If it has been helpful, if it has been useful to you, please like and follow. If you know somebody, please feel free to share this with anyone that you know. And of course, if you want to know more information, reach out to us. Let us know. Yet again, thank you for the folks on WVOE. Thank you for the folks that are listening live. And thank you to the folks that are watching the recording. We really appreciate you. Please tune in for us next week. Thank you.
All right, ladies and gentlemen, that was the Dr. Brown here at WVOE.